The first piece of this lecture is going to cover the assessment of fetal well-being and antepartum testing. Remember, you always have two patients. You have your fetus and you have your pregnant client, okay? So the only way that the baby can tell you how it's doing is by you understanding how to interpret the test and read the fetal heart rate monitor, which we've talked about. So our goal for antepartum testing is the optimization of maternal fetal dyad. You know, the dyad means two, so we're trying to make sure everybody's doing well and everybody's happy. Testing can identify an at-risk fetus before something catastrophic and irreversible happens. These methods for testing, I'm going to go over one by one. This picture here is a picture of something called a fetal acoustic stimulator or a vibroacoustic stimulator. So we use this to wake up the baby. So babies have sleep cycles. We've talked about sleep cycles and they're allowed to sleep. However, we need to make sure we can wake them up if we need to. All this is noise. And it kind of startles the baby and wakes it up. And if you put this on the mom's tummy and you push the button, it should startle the baby enough to where you should see something react on your fetal heart rate tracing. Whether it's a difference from minimal variability to moderate variability or now the presence of axons, you should see something once you use the vibroacoustic stimulator. To use this, you place the device on the client's abdomen and push the button for 1 to 3 seconds. So there are different indications for antepartum testing. There are tons of reasons actually, so I didn't put them all on here, but poorly controlled hypothyroidism, diabetes, hypertensive disorders, issues related to the pregnancy are these over here. So all of these things that we're going to talk about this in class this week, this in class this week, this in class this week, but the rest of the stuff I think that we've talked about already. This here is a picture kind of how the monitor is placed, although you know that from our previous lectures. So first we're going to talk about the ultrasound. You can do an ultrasound abdominally or you can do a transvaginal ultrasound. It depends on the reason we're doing the ultrasound, the preference of the provider, all kinds of things. But an abdominal ultrasound is a non-invasive way to look at this fetus and the environment it's living in. Again, we've talked about how the best abdominal ultrasound is used in the first trimester. We've talked about that. It's helpful if your client has a full bladder because what that does is it elevates that uterus up out of the pelvis so we can see a little better. A vaginal ultrasound is a little more invasive, clearly. It's done, but they use this vaginal probe, well, a probe that's inserted vaginally, however you want to say it, and that's how they see the contents of the uterus. They usually put some kind of a barrier on the probe, like a condom or something like that. Ideally, your client is in the lithotomy position, which means that they're up in the stirrups. Does not require a full bladder. This is super helpful if a client is overweight because on an abdominal ultrasound, there's that thick layer of adipose tissue between the Doppler and the uterus. Here, that's not there. So that's really helpful. And it can be used in conjunction with an abdominal ultrasound to help evaluate for preterm labor. A Doppler ultrasound is an external ultrasound. We use it to measure Doppler flow of the blood through the baby's heart. We use ultrasound for all kinds of things, and these are just a couple of things that I'm going to talk about. Confirmation of pregnancy, we've already talked about a lot of these things. Confirmation of gestational age, how far along is this pregnancy? Identifying if it's a singleton pregnancy or a multi-fetal pregnancy. To figuring out where the implantation has occurred. Is it fundal, which is where it should be? Is it ectopic, which is in the tubes? Assessing the growth and development of the fetus as well as the placenta. We can look at the structures of the maternal body, confirmation of viability or fetal death, detection of fetal anomalies. Where is the placenta at? Remember, it should be fundal, but do we have a low-lying placenta? We're going to talk about that in class this week, something called placenta previa, and an ultrasound helps identify that. Determination of amniotic fluid volume, we talk about that in this lecture here. Watching our fetus move, what is the position of the baby? How mature is this placenta? Remember, you get one placenta. It starts every day it's implanted is a day that it's older. As the placenta gets older and older, the functionality is less and less. So they'll grade the placenta to tell you how mature it is. All right. And to help other procedures like an amniocentesis, we're going to talk about this week, and a biophysical profile, we're also going to talk about this week. So again, this is another busy slide, but the idea, I wrote it this way, it was very intentional. I want you to kind of see the differences, okay? Because they're similar in a lot of ways, but they're different as well. So let's start with an NST. So I'm going to switch colors because I'm feeling like it. So an NST first. Both of these evaluations require both the Doppler to be placed as well as your TOCO, right? So we're going to say that. However, the NST only looks at the baby's heart rate. So it's the most widely used technique for antepartum fetal assessment, and it's done in the 3rd trimester. Sometimes we'll give our clients buttons. It's just like a Jeopardy button. If you watch the show Jeopardy and they have a little button in their hand, we tell the client to push the button whenever they feel fetal movement. So an NST just measures the heart rate. It doesn't measure contractions. It's either reactive or non-reactive. That's it. It's reactive, and this is what we want. This is our goal here. It's reactive if we have 2 or more 15 by 15 accelerations in a 20-minute period. We have a normal fetal heart rate baseline and moderate variability. So then it's a reactive tracing. That's good. Then that means she's done. But if it's a non-reactive tracing, that means that we have not met these above criteria in 40 minutes. So we have not established fetal well-being. So we need to do further testing. We don't just let them go home until we know that the baby's doing okay. So we're either going to do a biophysical or a contraction stress test. And the contraction stress test is over here. So where the NST just looks at the fetal heart rate, the contraction stress test looks at the heart rate as well as contractions, hence the title, right? A couple of things. A hypoxic fetus will respond to 50% of the contractions with late decels, all right? So this lets us know how the baby's doing in response to contractions, but we have to make your client contract. They're not supposed to contract early in the 3rd trimester, so we have to make the contractions happen so that we can evaluate how the baby does in response to them. We make the contractions happen by starting an IV of oxytocin or by using nipple stimulation with on the client. So when do we not use a contraction stress test? We don't if the client is preterm, so before the 3rd trimester, has placenta previa, we're going to talk about that this week, has an incompetent cervix, we're going to talk about that this week, has multiple, so more than one baby, and has a prior C-section with a vertical uterine incision. Because again, we've talked about this in the labor and delivery lecture. If you've got a vertical incision on that uterus, you don't want to cause contractions because it can rupture. So the findings, it's either positive or negative. So the confusing thing for my students is that positive is an abnormal finding. But think of it this way. If you have a positive CST, it means it's positive for lates. It's positive for lates. That means that with 50% or more of the contractions, we're having lates. Well, that's not good. We know that's not good. Or is it negative? That's a normal finding. If our CST is negative, there are no lates either within 10 minutes or within 3 contractions. So if we have a positive finding, again, we don't just send her home. We're going to call our doc and we're going to get orders to keep trying to establish fetal well-being. If we have a negative CST, she'd probably be able to go home. So here's an example of a reactive NST. This is a beautiful strip here. So here's our baseline, nice moderate variability, right? I hope you confirm now we're moving along here, so it's not our first day. We have nice accels. This is a great example of a reactive NST. As opposed to a non-reactive NST, there's no decels, but there's no accels either. So if I saw this, I would do fetal acoustic stim and see if I can get some accelerations. Here's an example of a contraction stress test. So we've got sometimes minimal variability, but we've got these nice accels, right? We've got these contractions here, and we've got no lates. So that's a negative contraction stress test. as compared to a positive contraction stress test. So here's the peak of our contraction, and there's the late. Here's the peak of our contraction, and there's a late, and so it goes. So this is a positive contraction stress test. Again, she may not go home. She's probably going to have further tests ordered so we can establish fetal well-being. So biophysical profile is one of those tests that we can do to establish fetal well-being. It's a non-invasive way to establish fetal well-being. Remember on the NST portion of this previous slide when I talked about the NSTs? And if you have a non-reactive NST, you can either do a contraction stress test or a biophysical. That's what this is. So it combines heart rate monitoring and ultrasound. You assess fetal well-being by measuring 5 things. Each one of those 5 things gets 2 points. So go down the line. Fetal heart rate, if it's reactive, it gets 2. If it's non-reactive, it gets 0. Fetal breathing movements. A couple of things about breathing movements. Sometimes my students get confused because they think, well, gosh, Dr. Dahl, babies don't breathe air inside their mom's tummy. Well, that's very true. So we're not watching the air movement. We're watching the movement of the lungs. There's fluid in there, but we're watching for that. So if there's at least 1 episode, baby gets 2 points. If there's none, it gets 0. Our gross body movements, we're talking here about 3 limb extensions, opening and closing of the legs, of the arms, and then fetal tone is another one. Amniotic fluid volume index, what they're doing is they're doing an ultrasound of the mom's abdomen and measuring, kind of dividing the pregnant abdomen into 4 quadrants. And they're trying to find at least 1 pocket that measures 2 centimeters. There can't be anything in that pocket. No cord, no placenta, no fetus. It has to be an empty pocket with just fluid. If in fact there is a 2 centimeter pocket, she gets 2 centimeters for that. If not, she gets 0. So our what does that mean? Findings of an 8 to 10 is a normal biophysical, so that's good. You would call your doc and say, my NST was non-reactive, my biophysical was 9. Can she go home? And they will say yes, so that's good. If you have a biophysical of 6 or less, that is abnormal. We should suspect fetal asphyxia. And I already kind of talked about the amniotic fluid index, but the AFI is what this is. Again, I kind of covered most of this. I covered that. Oligohydramnios is defined as AFI less than 5 centimeters. We already talked about oligohydramnios, how it can occur secondary because of rupturing of membranes and congenital anomalies in the fetal urinary tract. Remember, the baby's drinking in the fluid and peeing it out. So if there's an issue with the kidneys or anything in the urinary system, we're going to have an issue with our amniotic fluid. If oligohydramnios is discovered at term, and the parent and everything else is stable, they would go ahead and deliver the client. If it is discovered at preterm, they would further monitor the fetus. So quad marking is a test. It's like a fetal screening, a maternal screening test for fetal birth defects. If the test comes back positive, we're going to do further testing to determine if there are birth defects, things like an amnio or chorionic villus sampling. The quad marker is more reliable than an AFP, which is an alpha fetoprotein. That's what AFP stands for. The quad screen tests for 4 things. That's why it's called a quad screen. It tests for the presence of human chorionic gonadotropin, which is the pregnancy hormone produced by the placenta. It attests for the AFP, which is produced by the fetus. It tests for estriol, which is produced by the fetus and the placenta, and inhibin A as well. It's done between 16 and 18 weeks. And again, if it comes back positive, they're going to send this client for further testing to see if there are genetic defects at all with the fetus. Next, I'm going to teach you about an amniocentesis. I'm sure some of you have heard about this. An amniocentesis is where the practitioner inserts a needle into the pregnant abdomen and aspirates amniotic fluid and sends it off to the lab for analysis. We use an ultrasound to help use for visualization during this test. We perform this test after 14 weeks gestation. It's best for our client to have an empty bladder before we do this procedure. It can be used to assess neural tube defects in the fetus or for chromosomal disorders. Or if the patient is over the age of 35, they're going to suggest doing this test. And these are all the indications that we can do. The indications to have an amniocentesis. It can be for a previous birth with a chromosomal anomaly. If there's a parent who is a carrier of a chromosomal anomaly, a family history of neural tube defects, the prenatal diagnosis of a genetic disorder of a congenital anomaly, a lung maturity assessment, and fetal hemolytic disease. So I have a picture here that describes an amniocentesis and what it looks like. It is an informed consent procedure, so she'll have to sign a consent for it. And as a nurse, our role is not to help. We don't really perform this test. We really help hold the ultrasound so the practitioner can do the test. So the practitioner will get informed consent, and the belly is prepped with a sterile solution. There's a sterile barrier that goes over the ultrasound, and your nurse has sterile gloves on, and then we hold the ultrasound there. Then the healthcare provider is going to insert a very long, thin needle through the abdomen, through the uterus, and into the amniotic sac and aspirate fluid and send that fluid down to the lab. Now, I'm hoping you're thinking, well, gosh, if there's a hole in the amniotic sac, aren't her membranes ruptured? Isn't that a risk for an infection? Yes, all those answers are correct. So there are some complications of an amniocentesis. We can have an amniotic fluid embolism occur. We can have maternal or fetal hemorrhage, as well as maternal or fetal infection. We can have fetal death, a miscarriage, preterm labor, laceration to the cord of the fetus. This is one of those procedures that if your mom is Rh negative, she should get a shot of RhoGAM after this procedure, just in case there's any kind of mixing of blood that has happened during this procedure. After the procedure, we want to monitor the fetal heart tones, and again, we want to assess the parent's blood type and give that gamma globulin if needed, and monitor for symptoms of preterm labor and infection. The thing is that the needle is so long and skinny, 99% of the time, the little tiny hole that gets put in the sac from the needle kind of seals itself back up, which is nice. Chorionic villus sampling is another kind of test we can do to test for genetic issues with the fetus. This is a little more invasive as well, because what we're doing is we're actually going in and aspirating, that's the wrong word, kind of grabbing a piece of that developing placenta. We're grabbing a piece of the chorionic villi and sending that to the lab to get looked at. This is done in the first trimester. It can be done as an alternative to the amnio because it can be done earlier. The amnio is done after 14 weeks. This one is done between 10 and 13 weeks gestation. So it depends on what's going on and the reason why we're doing it. We want to instruct our patient to drink 1 to 2 glasses of water before the test, because what it does is it lifts that bladder up. Complications, loss of the pregnancy, infection. We also can have fetal limb loss, especially prior to 9 weeks gestation if it's done that early, because everything's really small. In the picture, you'll see on the top here, we have the ultrasound transducer there. And so she'd be up in the stirrups, and there's a speculum. That's what this silver guy is. And then they're going to put this catheter in. It looks kind of like a boba straw, for lack of a better term. And they're going to put this catheter in and kind of stick these little grabbers through the catheter. And they're going to stick the grabbers through the little straw and grab a piece of placenta and send that off to the lab. Percutaneous umbilical blood sampling, I've honestly never assisted with, so I only know what the book says here. So it's commonly called a cordocentesis. If you're going to do it, you might see in the prenatal record that this was done. It's done to obtain fetal blood sampling as well as do a fetal blood transfusion. They retrieve blood from the umbilical cord. They actually put this needle right here through the abdomen, through the uterus, through the membranes, and go into the umbilical vein. That's our goal here. It just sounds so precise. The reason that what we're testing for, Kleinhauer-Betke. Kleinhauer-Betke is a test that we do to see if there's any fetal blood in the maternal system. All right. They can do indirect Coombs, karyotyping, blood gases, and a CBC, but there's risk here with this as well. If your patient is Rh negative, with all of these tests, you would assess her Rh status, and then once it's confirmed that she's Rh negative, she would get a shot of RhoGAM. The final piece of this lecture is going to talk about perinatal infections. I know I've covered a little bit of this when I was talking about like the earlier intake of your pregnancy, but this will be a little more in detail here. So HIV, a little bit of HIV and AIDS. Most of us know what HIV and AIDS is, but it can be transmitted from the parent to the neonate via the placenta as well as breast milk. We'd like to avoid things like an episiotomy or an amniocentesis if somebody is HIV positive. Also, we're going to avoid all these invasive procedures as well. We already talked about ideally they're going to have a C-section. We want to delay vaccines until after the baby is bathed. If her viral load is real small, she can attempt labor if her OBGYN is okay with it. I think I've covered the rest of it. So torch infections, I also covered this. I'm sorry, I feel I don't want to go over things over and over again, but I went over really what these mean already. We want to adhere to our teaching to prevent our transmissions. We want to go ahead and educate our patients that, especially if they have herpes and they have an active lesions during closer to their due date, they will have to have a C-section to deliver their baby. Something I want to tell you about that. So you always want to know why your client is having a C-section, right? Is it because the baby's breech or whatever? Even if the scheduling book says that they're having a C-section for herpes, we don't want to tell the family that she's having a C-section for herpes. So what I usually do is I ask my client, how does your patient know the reason you're having a C-section? And a lot of times they'll say, oh yeah, I told them this. And then you want to make sure you support the patient and keep her private information private. So COVID-19, this is going to be an ever-changing slide, but for now, we all know what COVID-19 is. We're still living in this pandemic, at least currently when I'm recording this lecture in 2021. The ongoing global pandemic has heightened awareness of the health inequities experienced by people of color, low-income individuals, and people living in rural areas. Nurses experience overcrowding hospitals, lack of equipment to protect their health, and overall push nurses to their limits. Pregnant patients with COVID are at risk of becoming more severely ill than non-pregnant people. Pregnant clients with comorbidities like obesity and diabetes are at high risk of severe illness than their non-pregnant people with the same comorbidities. They are more likely to experience severe illness and death from the virus. If a parent is positive for COVID-19, they can still breastfeed. They don't have to isolate from their newborn. We want them to still be close with their newborn because the benefit of breastfeeding outweigh any of the risks of transmission of COVID-19. ACOG, which is the American College of Obstetricians and Gynecologists, recommend all eligible people, including pregnant and lactating individuals, become vaccinated against COVID-19. We kind of covered a little bit about GBS in the previous lectures. Who has a risk factor of GBS? If somebody has a previous culture that's positive during a prior pregnancy. Here are some risk factors of early onset GBS: a positive culture in the current pregnancy, prolonged rupture of membranes, preterm delivery, low birth weight, and intrapartum fever. The assessment of somebody who is GBS positive, we want to make sure we're watching for preterm labor and delivery, maternal sepsis, and endometritis after delivery. When somebody is GBS positive, when they're in labor, we're going to administer ampicillin or penicillin G IV piggyback every 4 to 6 hours until they have their baby. Ideally, you want them to get a couple of rounds in before their membranes rupture. And I already talked about the lab tests and how we do that. So a little bit about chlamydia. We did talk about it earlier. It is a really common reported STI. It's difficult to diagnose because typically the clients are asymptomatic, which would make it hard to diagnose. The CDC recommends yearly screenings for sexually active people who are less than 25 And for older clients with multiple partners or risk factors, they should be seen yearly. All pregnant clients should be screened in the first prenatal visit and in the third, again, if they're younger than 25 or have risk factors, and we talked about that earlier on in the class. If chlamydia is not treated, it can cause premature rupture of membranes, preterm labor, and postpartum endometritis. If chlamydia is transferred to the newborn, it can cause pneumonia and conjunctivitis. So these folks are at risk for getting chlamydia when you have unprotected sex with multiple partners. For men, there's the assessment we're going to have is penile discharge, dysuria, and some edema and pain in the testicles. For the females, we can have vaginal discharge, dysuria, and vulvar itching. So these are the meds that we treat: doxycycline and azithromycin. Erythromycin we give to the newborns in the ophthalmic gel, and we already talked about how to administer them last week in our home lecture. We need to educate our clients that they can pass this STI between partners and to use barrier contraception. Gonorrhea can be passed to our newborn during delivery. And typically, when a woman has gonorrhea, she is pretty often asymptomatic. If left untreated, it can lead to pelvic inflammatory disease and issues with infertility. In the newborn, the newborn can develop ophthalmia neonatorum. So these folks are at risk for developing gonorrhea. And it's kind of similar, actually, for the men for the findings of chlamydia, but the difference here for the women is they can have vaginal bleeding in between their periods and dysmenorrhea, which is painful bleeding. So we want to make sure that if we have a client who comes up positive for gonorrhea, that we identify and treat all their sexual partners. We want to make sure we administer erythromycin to all newborns upon delivery, encourage our clients to take their meds as prescribed and to do repeat cultures within 3 to 4 weeks once they've started, and educate our clients about safe sex practices. These are some complications that can develop if somebody has gonorrhea during pregnancy. We also screen for syphilis when somebody is pregnant. There are 3 stages of syphilis. Primary, they have a chancre there. Secondary, they have secondary, they have skin rashes on their hands and their feet. And tertiary syphilis, when you can have damage to their internal organs. It's confirmed via VDRL test. We treat with penicillin G, doxycycline, and tetracycline. You want to tell your client to abstain from all sexual contact until their sores have healed. We want to test and treat all partners. This is a reportable disease. An infection, and it gets reported to the CDC. If left untreated, it can be transmitted to the neonate, which can cause stillbirth or congenital abnormalities. So HPV is our next one we're going to talk about. HPV is a virus that's transmitted through oral, vaginal, and anal sex. It is recommended that we do routine screening for females between the ages of 21 and 65. If lesions are present, genital warps can interrupt a planned vaginal delivery. They'll require a C-section. When somebody has an outbreak of HPV, you can see there are noticeable bumps in the genital area. They kind of look like small cauliflowers. It's detected by doing a pap smear. And here are the screening times and guidelines per ACOG and the American Cancer Society. So they can give medication to treat the warts themselves, but the virus is always dormant. We want to encourage vaccinations in both males and females and discuss safe sex practices. The next STI we're going to talk about is trichomoniasis, and it also is spread through sexual contact. It can lead to PID in females, which can lead to infertility issues. People that are pregnant who have trichomoniasis are more likely to deliver preterm and experience premature rupture of membranes. These are the symptoms of somebody who has trichomoniasis. In men, we can have urethral draining and itching and irritation, and dysuria or pain upon ejaculation. In women, we can have yellow, green frothy, foul-smelling vaginal discharge, dyspareunia, and vaginal itching with dysuria. To treat trichomoniasis, we give metronidazole, which is Flagyl, if you know that name better. Once she's past the first trimester of pregnancy, she can take this. You don't want to mix alcohol with metronidazole because it causes severe nausea and vomiting. Bacterial vaginosis, typically just called BV, it's the most common vaginal infection in females ages 14 to 49. If left untreated, it can lead to PID, which again can lead to infertility issues. If it's untreated when she's pregnant, it can cause preterm labor and preterm birth. Risk factors, new or multiple sex partners, and the use of an IUD. I'll be honest with you, the use of the IUD, I have some literature that says that no longer is a risk factor for BV, but some books say it is. So that one's kind of hit and miss, okay? Expected findings on somebody who has BV, a thin white or gray discharge that kind of smells fishy, especially after sex. Education, these are the medications that you can take for it. These medications may decrease effectiveness of the birth control pill. If somebody has BV, you don't always have to treat their partners, and you want to educate about safe sex. Finally, we're going to talk about candidiasis, otherwise known as a yeast infection. A risk factor for this to happen is pregnancy, diabetes, someone who takes oral birth control pills, recent antibiotic use, somebody who's overweight, and a diet that's high in refined sugars. Somebody with a yeast infection has vulvar and vaginal itching and painful urination because the skin is so excoriated from the severe itching that happens when you have a yeast infection. Thankfully, it's easy to treat. You can get an over-the-counter cream once you diagnose this. You don't want to treat it without a diagnosis, though, so you have to go to the doctor to get it diagnosed. If you're not pregnant, you can take a prescription pill. It's a one-dose pill. It's called fluconazole. But if you're pregnant, you need to go ahead and use these creams. It's recommended to avoid getting a yeast infection. You avoid tight-fitting clothes. You wear cotton underpants. You don't use douches. Ideally, you want to increase your yogurt intake. And if the infections keep recurring, you want to make sure you screen for diabetes. So first, let's talk about bleeding during pregnancy. All bleeding during pregnancy is abnormal, and it should be investigated to find out what's causing it and to make sure something isn't wrong with the pregnancy. You can have bleeding happen anytime during the pregnancy, and again, we should check it out and figure out what's going on. We're going to go through each one of these things, so let's get going. So let's talk about a spontaneous abortion, otherwise known as a miscarriage, okay? So before I go any further, your healthcare team, your nurses, your docs, they're going to maybe call it a spontaneous abortion, but when you're talking to your patients, please say miscarriage. It's less confusing for them. So what a spontaneous abortion is a pregnancy that's ended all by itself before 20 weeks gestation. And there's classifications, and we're going to go through each one of those. These are the people that are at risk of having a miscarriage. All right, let's first begin with a threatened spontaneous abortion. So what's happening here when somebody's pregnancy is threatened? That means that they're experiencing bleeding. Their cervix, you see, is closed here, right? They might have some cramping. They may not. But again, they're still pregnant. There's still a heartbeat of this baby. They've not passed any tissue. This pregnancy is threatened. There's a chance they may lose it. When somebody's experiencing an inevitable spontaneous abortion, this means that inevitably they're going to lose their pregnancy, right? You can see as you read through it, it's progressing, right? Her membranes are going to rupture. The cervix starts to dilate. The pain's getting more intense. Their cramping's getting more intense. Nothing we will do will stop this pregnancy from being lost, sadly. It is a non-viable pregnancy. We need to make sure we support them and watch for, measure the vag bleeding. Those people who work in the emergency room, these patients are coming to you in the emergency room. Most often, they're not coming to labor and delivery. So just kind of understand that too. So next we'll discuss an incomplete spontaneous abortion. So when somebody has an incomplete spontaneous abortion, some of the products of conception are expelled. Let's pause for a second and talk about the verbiage of products of conception. Please do not use this statement outside with your patients. It sounds very cold. It sounds very uncaring, okay? Where we call this stage the products of conception, there's a very good chance that your patient is calling this stage their baby. So I don't want intent to be misunderstood by your patient, okay? But here, I'm going to call it products of conception because that's what we at the healthcare side call it, all right? So what's happening here? The placenta is still there, but the embryo, depending on gestational age, the fetus, the products of conception has passed. But the placenta is still inside, and you're aware because you've had weeks of lectures prior to this that anything that's left inside of the uterus can have a chance, can cause a postpartum hemorrhage. So look at your patient's going to have severe continuous vag bleeding. Well, yeah, that's because not all of the contents of the uterus were expelled. So the cervix is open. There can be tissue in the birth canal, okay? But again, this person's ultimately, we're going to have to do pad counts to make sure they're not losing too much blood, all right? And this person will probably have a DNC, a dilation and curettage happen to get the rest of the products of the conception out. All right, so this here lists the other types of spontaneous abortions. Let's go through these one by one, all right? So a complete spontaneous abortion or a complete miscarriage. I would guess if you have to experience a miscarriage, this is the one you want to pick because naturally the body gets rid of everything. All the products of conception are passed. This is what you want. So there's a decreased chance of a hemorrhage happening. Once everything is passed, the vag bleeding should stop. The cervix is closed. The pregnancy is fully ended at this point. A missed spontaneous abortion means that the patient has no idea that the pregnancy is over. They sometimes can have brown vag discharge. What happens is that they find that this baby has passed away in utero when they go see their healthcare provider and they can't find heart tones, all right? So this is a missed spontaneous abortion. The baby has died in utero, but nothing has come out. A recurrent spontaneous abortion is defined as 2 or more miscarriages in one patient, right? And so at this point, when we can diagnose this patient as having recurrent spontaneous abortions, there's things that we can do to try to help them when they get pregnant the next time. And we're going to talk about those here today. Your patient may or may not report cramping and vag bleeding. And they definitely will be they'll be losing their pregnancy because they keep having miscarriages over and over again. So you're going to see this lecture kind of goes down. It's set up the exact same way, all right? I introduce the topics. I try to have pictures if I can because I think it'll help you in your learning. And then I go to the assessment and management because this is the nursing, right? The beginning is understanding what the topic is. Here it goes into what are you going to do about it? This is the critical thinking piece. It's not enough to just recognize it. You have to be able to act on it, okay? So your patient, again, is going to come in depending on what kind of miscarriage they're having, right? Because it's not just one. So there's going to be some wiggle here on the management, right? It's important to understand that in all of these cases, this pregnancy is non-viable, all right? So if they're going to have their baby, they're going to have their baby. There's not much I can do about that. So they're going to present, or their complaint is going to be a backache, usually a dull backache, again, depending on gestational age, okay? They may or may not have ruptured. And again, I wrote will differ because it depends on the gestational age of the patient and what kind of spontaneous abortion they're having. So when they come into the ER, they go into the doctor's office with these complaints. They'll do an assessment and they're going to draw some labs. This right here, HCG, that's, I quote, I'm using air quotes here, the pregnancy hormone. It stands for human chorionic gonadotropin. Basically, when there's a pregnancy, as the pregnancy progresses, those labs are going to go up. That shows you that the hormone levels are where they should be. When you're losing your pregnancy, those levels are down. All right. So if somebody is losing their pregnancy or has lost their pregnancy, I would assume that the HCG levels are going to be lower than somebody who has a pregnancy that is progressing. All right. So this is what they're going to complain of. We're going to draw some labs and we're going to get an ultrasound to check for a heartbeat. We are going to, if the patient complains that they passed something when they were at home, they'll also check for the contents of the uterus. They were going to check somebody's cervix. They're going to do a D&C versus a D&E. A D&C, dilation and curettage, is in the first trimester, which is what we're talking about mostly. Now, if they lose their pregnancy in the second trimester, it's called a dilation and evacuation. They can also give medications to make somebody go into labor too. Again, this all depends on the gestational age of the pregnancy that is being lost and what kind of loss we are experiencing. But I already said, overall, the overarching thing is there's not much that anybody can do to keep the pregnancy happening. If it's a threatened miscarriage, they will send the person home and on pad and put peri pads in their underwear and to have them do pad counts and to have them come back and follow up either with their doctor if things get worse, like it's progressing. Okay, so they're going to be on bed rest when they go home. We're going to monitor vag bleeding and we can perform a pregnancy test, again, depending on the gestational age. Give them pain meds if needed. Typically, they don't need an epidural because everything is very small. But again, if you're at 20 weeks or 19 weeks, that's very different than if you're at 6 weeks. So it's very specific to your patient. What is their RH status? This you're going to see over and over and over again. If they're RH negative, they need to have the immune globulin injected to protect against future pregnancies. Now let's talk about an ectopic pregnancy. Sometimes people call it a tubal pregnancy because it is an abnormal implantation of this fertilized ovum in the fallopian tubes. As you know, we're supposed to have fertilized implantation happen in the uterus, right? But here it's happening in these tubes. It is the second most frequent cause of bleeding in early pregnancy and a leading cause of infertility. These are the individuals that are at a risk factor of developing an ectopic pregnancy. All right, so your patient who's experiencing an ectopic pregnancy still may have a positive pregnancy test. The most common symptom or complaint, it's a textbook complaint of somebody who's having an ectopic pregnancy, is this unilateral pain in the lower quadrant. So it's going to be on one side only and the quadrant where the implantation has happened. They might have vag bleeding, they may not, but this is the biggest telltale sign here. So they're going to present to their doctor or the emergency room, and this is going to be their complaint. The nursing staff there or the healthcare provider will order an HCG level to be drawn. We already talked about that. And then they're going to order a vaginal ultrasound. In these early gestations, it's more common to do a vaginal ultrasound because the ultrasound goes inside the vagina. That's why it's called vaginal. And the transducer is right up against the cervix, so they can really see into that uterus. And what they're going to find here is that the uterus is empty. All right? So ideally, once we diagnose somebody with an ectopic pregnancy, our goal is always to preserve the tube because your patient client only has two. They're born with two. If the tube ruptures, the tube has to come out and then they only have one, which is why there's a big issue of infertility, okay? So hopefully they've come into the ER early enough to where we can save the tube. And how they save the tube, they can do something called the salpingostomy, right, to save the tube, or they can give the patient methotrexate, which will dissolve the embryo, which again, a lot of my students hear that and I get like different responses, but this pregnancy is not going to carry. So we're trying at this point to preserve the organs of the patient so she can get pregnant again, okay? If your tube has ruptured, so if they came in too late and the tube has ruptured, the plan of care is different. What they're going to do is have to have surgery. So they have to sign consents for surgery. They have to remove the tube. And now we have to have that conversation of impossible infertility. Always there's a chance of a repeat ectopic. And maybe they didn't even know they were pregnant. So think about if you're an ER nurse and you don't want to work in labor and delivery, this is not something you enjoy, but then you work in the ER and your patient comes in with this pain in the right hand side and says, oh, I'm not pregnant. Well, come to find out, not only are they pregnant, they have an ectopic pregnancy. Their tube is now ruptured. The pregnancy they didn't know they were having, they're now going to lose and they have to have surgery. That's a lot of emotions. So they're going to need lots of support, okay? Again, what is their RH status? The next issue we're going to speak about is called gestational trophoblastic disease. It's also called a molar pregnancy. Did I write this anywhere? Molar pregnancy, okay? Lots of people use those terms interchangeably. It's pretty rare, but instead of where this is going to happen where the placenta should have attached, right? So there's no fetus, there's nothing in here. And instead of the placenta attached and the embryo attaching, we have these cluster of tumors. So these tumors start in the cells that would normally develop into the placenta. They become swollen like big fat grapes, okay? And it's this is the reason why this happens. It's very rare, which is good, because this is not a viable pregnancy. There's no embryo at all. All right. It's often associated with hyperemesis and it's diagnosed very early. So how will the patient know? We're going to talk about that on the next slide. So the patient's going to present to the emergency department. They may not even know they're pregnant again, but they're going to come in with excessive vomiting. Well, why? Because when somebody who has a molar pregnancy, their HCG levels are through the roof. It's one of the things that go with this kind of condition. And because your HCG levels are so high, it causes this excessive vomiting. They may pass prune juice, have dark, this purpley prune juice color, vag discharge, and that will be concerning, and that might bring them into the ER, or they actually might pass these little vesicles too, which would make them scared, and that might bring them in, okay? So when they come in, they're gonna run HCG levels on them, and the findings are gonna be very high. They're gonna order an ultrasound, and they're not gonna see any viable pregnancy in there. They're just gonna see this uterus that's swollen, and it's swollen and filled of these vesicles, okay? So what are we going to do about it? Well, they're going to have to go to surgery, and I want you to picture like a very big yonker, okay? So what they're doing is they're doing a suction curettage. What that does is that removes the contents of the uterus, all right? And again, what is their RH status? The next section of this content talks about the abnormalities of the placenta. And we've talked about the normal placenta, I'm using air quotes, the normal umbilical cord with Wharton's jelly. These are the abnormal things that we're going to find now. First, we're going to discuss a placenta previa and a placental abruption. A placenta previa is simply the placenta attaches to the uterus in the wrong spot. The normal place for the placenta to be is posterior fundal. When you have got a previa, the placenta is attached to the lower uterine segment, over the cervical os or near the cervical os. It results in bleeding in the third trimester, so not the whole pregnancy, and these are the different kinds of previas you can have, and I'm going to go over those with you. Placenta abruption is different. They both, yes, involve the placenta, but the abruption is the premature separation of the placenta from the uterus. Remember, this pregnancy is going along, the baby's just fine, and then all of a sudden, the placenta will separate from the side of the uterus. Well, as you know, the placenta is how the baby gets all of its nutrients. And when it's separated prematurely, there can be compromised blood flow and nutrient flow to the baby. It occurs after 20 weeks gestation, a significant maternal and fetal morbidity and mortality. In fact, it's the leading cause of maternal death in pregnancy, all right? Most often, following an abruption, we have things that happen like DIC, okay? And these are the kind of abruptions you can have, and we're going to talk about all of those. First, let's talk about placenta previa, right? So remember, your placenta is supposed to be here. I'm going to use a different color because this is already pink. Let's try blue. The placenta is supposed to be here. Posterior fundal. This is ideally where it's supposed to be. Well, here, the placenta is attaching very low. And in essence, the lower it gets, it's blocking the door. The door is the cervix, right? So what I want you to understand is that the lower the placenta, the higher the chance of having a C-section. Because the cervix, as it dilates, this placenta is going to be in the way. Also, the placenta's block is kind of throwing off the alignment of the fetus against the cervix. So those cardinal movements, even if this person were to go into labor, the cardinal movements we talked about in week 1 won't happen because we can't have the baby's head against the cervix because the placenta is covering the cervix. All right, so what are we going to do about this person who comes into labor and delivery, and what they're honestly going to present with? The classic sign of a placenta previa is painless vaginal bleeding during the 2nd or 3rd trimester. That's what's going to bring them in. Who is at risk for developing a placenta previa? Once you have one previa, your risk goes up of having more. Any kind of scarring on the uterus. Placentas are drawn to scarring. So if you've had a low cervical transverse C-section, well, there's a scar on the lower part of the uterus. The placenta is going to be drawn to that scar. It's just the way it is. Advanced maternal age, multifetal gestations, multiple gestations, and smoking. So again, the classic sign of a previa before even getting an ultrasound, the patient's going to present with painless vag bleeding during the 2nd or 3rd trimester, and the uterus is soft. There's no contractions there. When you put the baby on the monitor, you are not going to see any fetal compromise because the placenta is still attached. It's just attached in the wrong place, okay? So we're going to do some diagnostics. We're going to get an ultrasound. The ultrasound's going to show the placenta is going to be low depending on where it's at. We're going to get some blood work here, of course. Type in RH. There it is. And this is a test, Klein-Hauer-Becky, or Klein-Hauer-Becky. That's how you say that. Remember, the fetal blood and the maternal blood are not supposed to ever mix. But this test will tell us if they have. All right? So what are we going to do if somebody has a previa? Ideally, nothing. Ideally, we admit them into the antepartum unit and we monitor their vag bleeding and we just keep them on bed rest. Because the best place for this baby to grow is in the uterus until it's not. So if for some reason the person keeps bleeding and bleeding and bleeding and the baby starts, no, I'm not going to say that. If for some reason we can't control the bleeding, ultimately they'll have to do a C-section on her. People who have a previa have a C-section done, okay? We're going to limit our vaginal exams because if you go back to the previous slide where the picture is there, if you look at the slide, and you want to see how the placenta is either partially or in different variances fully covering the cervix. If you do a vaginal exam and put your fingers through your placenta, now you're going to have fetal compromise. Okay? So if somebody comes into the hospital and presents with vag bleeding, with no contractions, the abdomen palpates as soft, it's the right gestational age, establish fetal well-being, and call your healthcare provider and give a nice SBAR, and your recommendation should be an ultrasound. Do not put your fingers in that patient until you know where that placenta is. You don't want to be the person responsible for causing damage to the baby, okay? So now let's talk about abruptions. We've already talked about previas. So abruption, I already said, is the premature separation of the placenta from the uterus. And you can have different kinds of abruptions. This picture here is a central abruption. So here's what's happening. If you see right here, the only places that there's having fetal circulation happen is where it's attached. So right here and right here only. So this is why you're going to show fetal compromise on the monitor, because half your placenta is not being perfused. What's happening is that the inside of the placenta, the center, hence the center of the placenta is being lifted up and blood is pooling inside the center of the placenta. But because the sides are still attached to the uterus, there's no place for the blood to come out. So what happens is the blood gets soaked up into the muscle. All right. I want you, before I go further, I want you to look at your hand right now. And then if you were to kind of cup your hand, so where your knuckles are pointing back, there's a little cup in the palm of your hand. That would be where your central abruption is. Your fingertips and the bottom of your palm are going to be where the placenta is still attached to the uterus. So in this gap, if you will, of your hand is where the blood is pooling. And because the placenta is still attached all the way around, just the middle or the center is lifted up, there's no place for the blood to go. So what happens, the blood gets absorbed into the muscle, leaving what we have called a Corvellier uterus. You can look it up. I don't know how to spell it. But what it basically means, and this is what this picture is. This is actually a patient that I took care of. I have permission to use pictures for my show here. So what you're looking at, this is somebody's thumb. So the patient's head is here, right? And there's arms here and legs here. So this is their uterus. The baby is delivered. The placenta is now out. The person delivering the baby, the healthcare provider, this is their thumb, and this uterus is very boggy, very boggy. And all you're seeing here, all of these dark spotches is blood that is absorbed into the muscle over here because there's no place for it to go. The problem is when you've got blood in this muscle, it causes uterine atony. And as you know, uterine atony is the leading cause of postpartum hemorrhage. I've had students in the past ask me, well, can't you just take a syringe and go in and aspirate the blood, which is a fantastic question, but you can't do that. It doesn't work that way. So what you have to do is give uterotonics to help that uterus contract. These two pictures here are different kinds of abruption, and you can see both this one here and this one actually more than likely. I'm gonna make an adjustment to this picture. When you have a complete abruption, there's nothing that is attached. So what you would see in reality is blood that is running out of the vagina like this. Okay, continuous, because the placenta is just free floating in there. Both of these things, your baby can die very rapidly, depending on how much of this placenta is separated. The more that's separated, the greater incidence of fetal death. Okay, which makes sense because there's nothing perfusing this baby, right? So it's going to die very quickly. So again, they're going to complaints. Usually at this point, if the patient's at home, they're calling 911 and they get brought to us in labor and delivery by an ambulance. And we just hope that it was fast enough where the baby has not passed away. All right, so let's break all this down here, okay? So what are we going to do about it? So first, let's talk about who is at risk for developing a previa. Hypertension. Okay, any kind of blunt force trauma to the abdomen. We're talking about auto accidents, domestic violence, okay? Anything that we have fall, anything that can have blunt force trauma to the abdomen. Certain drugs, cocaine, amphetamines, okay? Smoking, and previous abruption. Those folks are at risk. So they're going to come in, and the classic sign, I told you a classic sign of a previa earlier, a classic sign of an abruption is a sudden onset of intense vag pain with dark red vag bleeding and a board-like abdomen. So it's not soft at all. You're gonna hopefully get heart tones unless the baby's already died. So you'll put the toco on and you're gonna put the Doppler on and you're going to see an abruption pattern instead of they're called hypertonic contractions. So they kind of look like this on the monitor, as opposed to regular contractions look like that. So you're going to see an abruption pattern like that. You're going to see fetal distress depending on how much of the abruption there is. If it's a tiny abruption, maybe not as much, okay? So depending now, if it's a complete abruption, you got to move before the baby dies. All right, so if you can establish you've got a complete abruption because you have done an ultrasound and basically on your assessment, you're really quickly going to go have a C-section to try to keep the baby alive. All right? However, if you have time, you're going to get blood work done, all right? With the understanding that the biggest complication besides death of both mom and baby is DIC. This slide is created just so when you're studying, you can tell the difference between them two. Next, we'll talk about an invasive placenta. It's the placenta. This is all about the wrong attachment. We already talked about a previa, which is it's the incorrect place. The abruption is is premature separation, and this is invasive placenta. It's the abnormal attachment to the uterus, and there's 3 different kinds of an invasive placenta. You can have a accreta, an increta, and a percreta. And if you look at the picture, what's happening is the placenta is going deeper and deeper and deeper into this muscle, because as you know, normally placenta is just attached. They don't go through. So basically, with an accreta, the placenta is going into the uterine wall. An increta, it gets deeper into the uterus. See, it's farther in. It goes into the myometrium. And a percreta goes through the muscle and can attach to organs around it. All right? Again, with the understanding that placentas have an issue with scarring in the past, they're drawn to scars. So it's related to placenta previa and a history of multiple C-sections. So the more C-sections they've had, the higher the risk for an invasive placenta. There's also a high incidence of hemorrhage and hysterectomy here. Now let's talk about vasa previa. So what is vasa previa? Just like it says here, a vasa previa happens when fetal blood umbilical vessels implant into the membranes instead of the placenta. Now I want you to think back on week 1. We talked about, in the home lecture, I believe, we talked about the Wharton's jelly and the umbilical cord, and that's where those vessels are supposed to be. Here, this doesn't happen. They go into the membranes. There are different variations of vasa previa. Okay, so first we have velamentous insertion of the cord. So here, this is exactly what this picture is. This is the vessels that are running through the membranes. There's no Wharton's jelly. So I'm going to draw this picture out for you. So up here would be the baby. And the umbilical, so this is the umbilical cord that's attached to the baby's tummy, right? You know that. And so here begins your umbilical cord with your Wharton's jelly. But then, instead of the umbilical cord implanting in the middle where it's supposed to, it goes through the membrane. So what you're seeing here, this is fetal membranes. This is fetal membranes. This is a big emergency. Luckily, if the person has had prenatal care, we diagnose this on an ultrasound and we admit them to antepartum. The reason is because if this person's water bag breaks, it can cause exsanguination of the fetus and that both the mom and the baby can die. So we want to make sure that they're admitted and they're close by in case their water breaks. We can get them into the C-section room. Ideally, their water doesn't break, right? Ideally, they stay pregnant, the baby's just fine, and then at about 37 weeks or so, they're going to schedule this person for a C-section. And this is the reason, all right? A sexenterate placenta is this here. So this is not as common. So this picture came directly from the internet. This placenta, when you have this kind of placenta, there's 2 lobes. So normally there's only 1 lobe. You know that, right? So this is what will be delivered. Now, what would happen if your patient had a sexenterate placenta and we didn't know it and only this part came out, you would look at it and be like, oh, it's all intact. But the problem is this would still be inside. And so that can cause a postpartum hemorrhage. So hopefully, again, the person has prenatal care and we can pick this up on ultrasound. The next one here is a battledore placenta. So again, remember, I'm going to change colors. I think it's easier to see. The normal implantation of the Wharton's jelly is in the middle, right here. But here, this umbilical cord and inside the Wharton's jelly is off to the side. That's called a battledore placenta. It's a marginal insertion of the cord. All 3 of these are at risk, puts the mom and the baby at a risk for a hemorrhage. So the next thing we're going to talk about for this content are medical conditions that are associated with pregnancy. The first thing we're going to talk about is a condition called hyperemesis gravidarum. Most of us just shorten it to hyperemesis, but what it is excessive nausea and vomiting that last after 16 weeks gestation. Now remember, this is a problem because this pregnant person is growing a human being, and if they're throwing up so much that they're dehydrated and they're having weight loss and electrolyte imbalances, that can affect the growth of the fetus. So this is really a complication here of pregnancy. Who's at risk for having hyperemesis? Here. People with those situations there. All right. And so what are we going to do? Sometimes we'll admit them into antepartum. We're going to give them an IV hydration, certainly antiemetics, and sometimes you can admit them to antepartum and give them TPN and lipids. Next, we're going to talk about gestational diabetes. Well, you already know what diabetes is. You know it's about impaired glucose. Well, now we have impaired glucose in pregnancy. So this is the ideal blood glucose during pregnancy. All right, so people that are experiencing gestational diabetes are an increased risk of having a big baby, which is macrosomia, of having infections happening, too much amniotic fluid, ketoacidosis, and issues with blood sugar, okay? Who is at risk for developing gestational diabetes? Here, these are the risk factors to develop gestational diabetes. So it's common practice for every person who's pregnant to have a glucose tolerance test. Now, do they have to? Nope. Nobody has to do anything. It's their body. It's their right to refuse. All we do as a healthcare team is to tell them why it is recommended that they get this screening done. And they can ultimately refuse, but you want to make sure they have enough information to make an informed decision. But let's go on the assumption that this person's not going to refuse. So we're going to go ahead and do a glucola and 1 hour GTT done at between 24 and 28 weeks. So when somebody gets this done, they're not fasting. They're going to go to a double lab appointment. They're going to go to the lab and drink 50 grams of this thick, not thick, it's like more of like it's a clear liquid, but it's thicker than water. It's an oral glucose because there's lots of sugar in there. And then an hour later, they're going to get their blood drawn. And if the results are positive, they're going to have to follow up with a 3-hour glucose tolerance test. If the results are negative, they won't. Okay? But let's go with the conversation anyway, that we have an elevated glucose tolerance test. So now we're going to go ahead and have to get this scheduled again, but we're going to have a more in-depth test to really make sure that yes or no, this patient has gestational diabetes. So it's a little bit different. For a 3-hour GTT, they've got to be fasting. So with the 1 hour, they don't. So they're going to come to the lab. They're going to get their blood sugar tested, and they're going to increase a more. So this one on a 1 hour GTT, it was only 50 grams. For a 3-hour, it's 100 grams. And then they're going to draw the person's blood sugar 1 hour, 2 hour, and 3 hours after ingestion. All right. And then if that's positive, then that is the diagnostic that they have gestational diabetes. Also, they will be spilling ketones into their urine. So what are we going to do about it? Well, I will tell you that more often than not, most oral hypoglycemic agents are contraindicated in pregnancy, which means they have to either be on diet control or they have to be on insulin. Okay? Daily kick counts, what does that mean? Well, what we're going to talk to the patient about is that babies move and they should be moving what their normal movements are. So we want the patient to be lying down for 30 minutes a day, and their healthcare provider will tell them how many movements they should feel within that 30 minutes to an hour. Next, we're going to talk about hypertensive disease in pregnancy. So it's divided into these subsets, and we're going to talk about all three of them. And what I want to tell you is that one leads to the other. And ideally, we can stop it. We don't want it to progress all the way down here, but they kind of go from one to the other like that. Let's talk first about gestational hypertension. And it's I tried to make it as clear as I could here. So this is not somebody who has essential hypertension. This is not somebody who had hypertension and then got pregnant. Okay, that's different. This is somebody that did not have hypertension, but now that after their 20 weeks of pregnancy, they now start having hypertension. So this is gestational hypertension. There's specifics about blood pressure. We're not spilling any protein here. And at 12 weeks postpartum, the blood pressure returns to its normal baseline. All right, so let's talk about these issues here. So we have preeclampsia, which can progress to, that's supposed to be let me erase that. There we go. That was very messy. Which can progress to severe preeclampsia, which can progress to eclampsia, which are seizures. All right, so again, we're trying not to get it to progress down this cascade here. So let's talk about preeclampsia first. So now our patient with a gestational hypertension now is spilling protein in their urine, okay? We're having some edema. Our pressures are still a little bit high, and look, our urine output is going less, all right? So it's hard to say. They may admit this person here and start them on medication to bring those pressures down because, again, we're trying to keep them pregnant as long as we can. Or we don't catch it, and now they're severely preeclamptic. So their pressures are higher. Look, 160 over 110. We're now spilling 3+ protein or greater in the urine. Our urine output is minimal. We're having elevations in our creatinine. Now your patient is symptomatic. Up here, they're not symptomatic, except for the edema, but they're not really experiencing problems. But here we have a headache and blurred vision. If you were to check their reflexes, they're hyperreflexic. A normal DTR, let me write that down. A normal deep tendon reflex is +2. So when somebody's hyperreflexic, they're going to be more than +2. They're having extensive peripheral edema. They're complaining of epigastric pain. They don't call it that. They're going to have complaints of heartburn. Okay, so heartburn in pregnancy is a normal thing, right? Because the pregnant belly, the uterus, is pushing on all the organs around it as it grows up. This is not that. People that have severe preeclampsia, they don't, unless they're a nurse or a doctor or whatever, but if they're the average people, they just know they're having heartburn. Well, what's happening, they're not having heartburn. Their liver's involved now, right? We're having issues with our creatinine, our liver's involved, and the pain is coming from the liver, and that's the epigastric pain that they're having, all right? So again, we're going to admit them, try to get their pressures down because we don't want them moving into this stage. This stage is called eclampsia. Right now, we're having seizures. I want you to think about your baby. There's always two patients. There's the pregnant person and there's the baby. If the pregnant person is seizing, what do you think is happening to the baby? Okay, so we really don't want the patient to progress in becoming eclamptic. Severe preeclampsia with the onset of seizures is the definition of eclampsia. And it's preceded by these things. So again, I'm hoping that the patient who is here in severe preeclampsia is going to call their healthcare provider and let them know that they're experiencing these things, and then the healthcare provider will send them to the hospital for a workup. The last thing I want to talk about on this slide is something called HELP. Okay, HELP is not like, hey, I need help waving your hand in class. HELP is a variant of gestational hypertension, and it's diagnosed by labs and not by symptoms, okay? So when somebody is in HELP, they have these things happening. The H is for hemolysis. EL is for elevated liver enzymes. Again, we talked about the epigastric pain. And LP are low platelets. So they have, their platelets are less than 100,000, which can lead them to DIC. Once somebody's in HELP, they're very sick. And we're really, again, trying to figure out how we're going to do a C-section on them. When somebody is in HELP, they're having a C-section done. But it's kind of scary because their platelets are low. So that's kind of a concern there too, all right? Okay, who is at risk for developing hypertensive disease in pregnancies? All of these people right here, all right? All right, I think those are all self-explanatory. So when this person comes to see you in the hospital, what are you going to do about it? All right, so what we're going to do is we're going to put them on the monitor. We're going to assess their vitals. We are going to assess their level of consciousness. Obtaining daily weights is going to depending on how severe they are. If they're having seizures, we're not doing daily weights. But if we're going to admit them to Antepartum, we can do daily weights. Performing an NST and daily kick counts and monitoring INO. We also are going to give them medications to help with this issue. There's two things we're going to talk about. First, we're going to talk about magnesium sulfate. So we're first going to give them an IV we're going to start an IV, typically lactated ringers. Then we're going to start a second IV. It's not really a piggyback, but it's a second main line into this line here. And it's magnesium sulfate. Magnesium sulfate, the idea behind this is not to decrease the blood pressure, but it's a vasodilator. So it's going to increase the blood perfusion, which is going to relax the uterus, and that's how it works, okay? So how it works is that we are going to give a whole bunch of mag right away. Okay, so when somebody has hypertensive disease in pregnancy, we're going to give them a 4-gram loading dose over about 30 minutes, and then we're going to slow it down to 2 grams an hour. During this 4-gram loading dose, for sure, your patient's going to complain of feeling hot and flushed and tired. They really, really hate the way it makes them feel. During this loading dose, we don't leave them. And we're taking blood pressures every 3 to 5 minutes, depending on the hospital policy, all right? Once somebody is on MAG, if they're term and they're going to let them labor, again, it depends on how severe the hypertensive disease in pregnancy is. They're either let them labor or not. They're going to be on the magnesium all through labor, and then 24 hours postpartum, because we know that the hypertension can kind of resurface in the first 24 hours after postpartum. We're also ideally going to have therapeutic MAG levels drawn to make sure that the MAG is at a therapeutic level. They're also going to give medications to decrease the blood pressure. The MAG prevents the seizures, and because it's a big vasodilator, it's going to drop the blood pressure too, but that's not why we give it. We give the MAG to prevent the seizures, okay? But we also need to give medication to keep the blood pressure low, to keep it stable. And these are what the different medications can give, and that's going to depend on your healthcare provider. So let's talk a little bit more about magnesium. So it's a heavy-duty drug. You guys are not going to be administering magnesium. I hope you have a patient that's on it. It's a very nice care plan right up here. So you can have side effects of this medication for both of your patients, the person who's pregnant as well as the baby. Okay, and that's what you can see there. When somebody is on magnesium, it can be really hard on your kidneys. Plus, if they're sick enough to be on magnesium, their kidneys aren't working that well anyway. So you want to put a Foley catheter in. And again, follow your policy of the hospital. But it's not uncommon to have a Foley catheter put in with the urometer there, because you can measure really closely the urine output. They're going to be on MAG levels every 6 hours or so. We want to be checking our blood pressure and our DTRs more often. Continuous fetal monitoring, because again, it goes to the baby, and strict bed rests with the understanding that there's an increased risk of a DVT when they're on bed rest. This is a big time drug, and you can become toxic on magnesium. And how would you know? You would know because of your lab levels. That's one way, but more often than not, your patient's going to feel it before you can get your lab levels drawn. They're going to put their call light on and they're going to say, I'm having a hard time breathing, or my chest feels heavy, or my arms feel weak. They're going to have complaints of something. You're going to go in, you're going to do their assessment, get a set of vitals, get your healthcare provider on the phone, and give a nice S-bar, and your recommendation is going to be, can I get a MAG panel? They might have you give calcium gluconate, which is the antidote for magnesium. And again, like I keep saying, a lot of the things that we do in labor and delivery are order sets. So when you get an order for magnesium to give magnesium to your patient, automatically in your MAR is going to be the antidote to reverse the magnesium. Okay, so that's going to be there. Next, we're going to talk about cervical insufficiency. What that means is the cervix does not sufficiently stay closed and it dilates early. And when it dilates early, the person can have their baby early. So premature cervical dilation is what's happening. Typically, there's no pain associated with this. There's no contractions associated with this. It just happens. Who is at risk for developing cervical insufficiency? People here. If they have cervical trauma, for example, you might be thinking, how do you get cervical trauma? The first thing I think of is if they've had medical procedures on their cervix and they may have taken biopsies and those kinds of things. That's traumatic to the cervix. Somebody who has a history of very short labors, early pregnancy losses, and then structural abnormalities of the uterus and or cervix. So those are the folks that are at risk. for having a short cervix or cervical insufficiency. So how would they know it? It's really hard to diagnose this because oftentimes it's not, the symptoms are really vague. They might feel fullness in the pelvis, pressure in the pelvis. They might have lower back pain, but it's not huge, it's just achy. They might have vaginal discharge. But again, does that always mean that you're having a cervical insufficiency? No, it doesn't. What it means is you have to go and get checked out. So they're going to come into the hospital and they're going to say, this is my complaint. We're going to put them on the monitor. We're going to make sure the baby's doing okay, see if they're contracting. We're going to do our assessment on them, and we're going to call our healthcare provider, and give a nice S-bar, and our recommendation is to get a vaginal ultrasound. Okay? Because a vaginal ultrasound is going to let us know how long that cervix is. Now, as you know, your cervix, this is in week 1, the cervix shouldn't start to dilate or efface until we get close to our due date. Well, here it could be happening earlier, and the ultrasound's going to measure the length of the cervix, and if it's dilated, the ultrasound will see that too. So the ultrasound's going to show a short cervix, and it's measured in millimeters. It might show effacement, and it might show funneling. Something is funneling. It means the cervix, instead of looking like this, which is closed, and here's the baby, right? It looks like this. It's getting shorter and weaker. Sometimes you can have beaking membranes, which means those membranes, if your cervix is dilated, the membranes kind of come through like that. So what are we going to do about it? We're going to admit them, and hopefully we can have a conversation with them about a cerclage placement, and that's the next slide. They're going to be put on bed rest. We want them to not have anything in the pelvis at all, in the vagina, so no sex at all. And we're going to observe them. So cervical cerclage goes hand in hand with what I just talked about. It can be elective or emergent, and I'm going to describe both of those to you. Ideally, you want to place this early, before 23 weeks. I'm going to talk to you about elective versus emergent. Elective means that your patient has had losses before, so they're going to put the cerclage in to prevent a loss again. That's what an elective is. An emergent means that they've come into the hospital and they're having complications. The cervix is getting shorter, maybe beginning to dilate a little bit. They're going to place an emergent cerclage to sew that cervix shut. And what it is, it's one big suture around the cervix like this. One big suture. And it's holding it closed. Kind of like a gym bag. Like a cinch bag, if you will, right? So if you pull the cinch bag and close up the neck of that bag, same idea. You're putting a suture around that cervix to close it up. Complications of that can be rupturing of membranes, certainly if membranes are beaking or close to the top there. Preterm labor, because anytime you do a pelvic exam or bother the cervix, certainly doing a surgical procedure, it releases prostaglandins. Prostaglandins can cause uterine irritability and contractions. So that's the deal with that. Also, you can have bleeding because you're putting a needle in the cervix. Post-op, they're going to give medications called tocolytics. We're going to talk about those, I think, in the next 2 slides. What tocolytics are, I already kind of talked about tocolytics in week 1 when I talked about tachysystole, because we gave medication called terbutaline if we're having tachysystole, and that's also what we could give in this situation too. So they might give antibiotics because of the invasiveness of it, and we're going to watch for infection and vag bleeding and labor. So in a perfect world, the cerclage holds that cervix closed, and now the patient's at 37 weeks pregnant. What they're going to do is they're going to pull the suture out and allow her to go into labor and have her baby at that point. All right, so we're going to almost finishing out this content here. Next, we're going to talk about preterm labor, and I believe that finishes us out here. So preterm labor is the onset of regular contractions that cause cervical change, because contractions that don't cause cervical change is not labor. So we have to have cervical change happening between 20 weeks gestation and 36 and 6. That's your preterm piece. The categories are here, okay? And then what are we going to do about it? So the patient's going to come into the hospital and they are going to tell you, I am having this happening. So what we're going to do is we're going to put them on the monitor and we're going to watch for contractions, okay? They may complain of contractions. Sometimes they may or may not hurt, but they can feel their abdomen getting tight. They may have some lower back pain, some cramping, and changing of course in cervical dilation. So this screen here talks about all the individuals who are at risk for developing preterm labor. It's a lot. And again, I do think that this is all pretty self-explanatory. I'm going to point this one out. Jobs that require prolonged standing, teaching, nursing, all kinds of things, working at a grocery store. So, you're going to have to ask those kinds of questions. Short interval between pregnancy. I always thought this was very interesting. The closer your pregnancies are together, the higher you have a risk of having preterm labor. So again, this is more tests we can do to help diagnose preterm labor. The caveat is that if somebody is asymptomatic, we're not doing it, right? This is for somebody that's having complications of pregnancy, like preterm labor. So they're going to come into the hospital. They're going to say, I'm experiencing the things that were on that first slide. You are going to put them on the monitor, get a set of vitals, do an assessment on both the patients, because there are two, and you're going to call your healthcare provider, and you're going to give a nice solid SBAR. All right. You can anticipate, honestly, all three of these things to be ordered. All right. Under the recommendation, you can recommend it, or they may just give those orders to you. So this talks about, this is a vaginal ultrasound, typically not done abdominally, because abdominal ultrasound has to get through the skin and the fat and the muscle, but the vaginal ultrasound goes right up against the cervix. All right. You might get an order for cervical cultures, because again, we know that infection can lead to preterm labor. And you might get an order for a fetal fibronectin followed by a vaginal exam, and it must be done in that order. Okay, so let's talk about what this is. What is a fetal fibronectin? So this is a protein that we can expect in early and in late pregnancy. And if you are having this protein happen between 24 and 36 and 6 weeks, if that means that there's a high risk that this person's going to go into labor in the next 2 weeks. So what that means is a positive fetal fibronectin tells us that we're positive for this protein at this gestational age, and there's a high risk of having a delivery in the next 2 weeks. The caveat for this is that you can't have anything in the vagina for 2 to 3 days before you get this done. So before you call your healthcare provider and do your SBAR and ask for a recommendation of this, you better ask your patient if they've had a vaginal exam, vaginal ultrasound, sex, anything in the last 2 to 3 days, because if that's the case, you can't do this test, okay? All right, so we're going to assume that nothing has been in there for 2 to 3 days. So we're going to get our orders for a fetal fibronectin and a vaginal ultrasound and a vaginal exam after we get the fetal fibronectin. So we're going to go into the supply room, and we're going to get a fracture bedpan. We're going to get a speculum with a light so we can see in there, and we're going to get the fetal fibronectin kit. And in the kit, there is a test tube and that has a little bit of fluid at the bottom, and there's a Q-tip that is that you can snap apart. Oh, it's scored. That's the word I was thinking of. So you can snap it apart when you're done, and you're going to go ahead and get some gloves on there. All right, then. So you're going to go to see your patient, and you're going to tell them, I talked to your doctor, and I'm going to do this test on you, and I'll walk you through it. And what the test, a positive test means that there's a high chance you're going to deliver in the next 2 weeks, and at that point, we'll probably admit you, give you medication, and if the test is negative, we'll probably send you home. All right, so that's fine. So what you're going to do, and some of you will see this done in clinicals. If you don't, we'll have you guys talk. Those who do, we'll have you talk about it, because you can teach each other, right? So you're going to put the patient on an upside down bedpan. The reason you do that is it puts them in a pelvic tilt so you can see the cervix. You want to make sure you can see what's in there. It's dark, and you got to make sure you can see everything. You're going to open up all your supplies. You're going to get your gloves on. You're going to put the speculum in with the light. Turn the light on so you can see. You're going to take your Q-tip. So here, I'm on step 2 now. You're going to take your Q-tip, and you're going to stick it in what's called the posterior fornix of the cervix, which is behind it. And you're going to spin it there for about 10 to 20 seconds. You're trying to pick up if there's any fetal fibronectin in that spot. All right. And then you're going to take the speculum and, well, the Q-tip out first and the speculum. Then you're going to put the Q-tip into the test tube, snap the Q-tip off, put the lid on the test tube, put a patient label on it, and send it to the lab. All right. And then you'll have your orders for a vaginal ultrasound, which you do after you get this test done. And then you can do a vaginal exam if needed, if that's ordered. But again, not until after you get this test and send it to the lab. So we are going to go with the conversation that we have a positive fetal fibronectin. So more often than not, they're going to admit somebody with a positive fetal fibronectin into the antepartum unit. They'll be on bed rest, maybe with bathroom privileges, depending, maybe with a commode, just depends on your provider. And they will probably be given a tocolytic to stop their contractions. Nifedipine is procardia, right? You guys know that. And it's a calcium channel blocker, and it suppresses the contractions because it blocks that calcium channel blocker, right? And then terbutaline is one that we talked about in week 1 when we talked about tachysystole. Terbutaline is given sub-Q, and it relaxes the muscles and makes contractions go away. The thing with terbutaline, before you give it, you need to make sure you check the patient's heart rate. If the heart rate's above 120 or 130, or the pressures are too low, we're going to go ahead and we are going to hold it. We also might get orders to start magnesium as a tocolytic. Okay, so we already talked about magnesium to prevent seizures when somebody has hypertension, but now we're talking about magnesium as a tocolytic. So magnesium sulfate goes through the IV. It's the same drug I already talked to you about in like 3 slides ago. So the difference is the dose that you're going to give and the goal, right? The goal here is to relax the uterus because this person's having preterm labor. So when don't we give it? If we have active vaginal bleeding happening, let's figure out why we have vaginal bleeding instead of just giving them mag. If our dilation is greater than 6 centimeters, chances are good no matter what we do, it's not stopping. That's advanced dilation, and we really can't do much about it at that point. If we have an infection, which is chorioamnionitis, typically greater than 34 weeks gestation, they're not going to give it, or acute fetal distress, because this is going to stress the baby out. So we're not going to give it if it's already stressed out. You don't want to double up on your tocolytics. So typically they're going to give magnesium and then they're going to hold everything else until they wean the patient off magnesium, and they might follow up with something else after that. Your dose is different than when the dose that you give for gestational hypertension, all right? And we talked about toxicity, which is the bottom there. The third reason you can give magnesium sulfate is for fetal neuroprotection, neonatal neuroprotection. So if there's any chance that this patient's going to deliver early, the researchers say it's helpful to give magnesium for 1 to 2 days, because it protects the brain of the fetus, so it decreases the chance for the baby developing cerebral palsy. Now I want to talk to you about steroids. Steroids that you can take when you're pregnant. We take this for somebody when there's a chance, like it says there, your first little bullet. All the bullets are kind of far off to the side, but the medication, the steroid that we use is betamethasone or celestone, okay? And with the understanding that neonates that are born before 37 weeks gestation have a bigger risk of complications with the respiratory tract, all right, than its term counterparts. So the research says if we can give the pregnant person steroids, it helps to speed up the maturity of the fetus's respiratory tract, all right? Ideally, we're going to give steroids 24 hours apart, and it's intramuscular. And again, it enhances fetal lung maturity. So here, this right here, I'm not going to read this to you, but this is the dosing and when you're going to give it, okay? So it's 12 milligrams in the vastus lateralis. Ideally, we want to give it 24 hours before the patient delivers. Be mindful if your patient's a diabetic, because as you know, and if you have forgotten, I want you to look it up in your farm book, the issue with diabetes and steroid use. We don't not give steroids for the diabetic, but we'll have to just check their sugar more often. They might need insulin to kind of cover it. But the drug works really well. The thing is that the nice thing about giving somebody steroids is not really risky. Let's see. The benefits outweigh the risk is what I'm trying to say. So if your patient has a risk of delivering early and they're giving her steroids here and she doesn't deliver early, it's not going to hurt anything. But if there's a risk of her delivering early and she doesn't get steroids, it's really, really devastating to the baby. So we want to make sure that we get these steroids on board. Here are the benefits to the neonate. Decrease in respiratory distress, decrease in intraventricular hemorrhage, decreasing chance of NEC, and decreased fetal mortality. The last thing we're going to talk about with our time together today is pre-labor rupture of membranes and preterm pre-labor rupture of membranes. That's a lot. First, we'll talk about pre-labor rupture of membranes, or PROM, which is a spontaneous rupture of membranes prior to labor. Okay, so pre-labor, that can really be any gestational age. That just means that somebody's water has broken before they went into labor. PROM. Now, the issue for this lecture, we're talking about the prematurity here, right? Because we already talked about the term labor, which was week 1. Now we're talking about prematurity. So pre-labor, premature rupture of membranes, otherwise known as PPROM, is when you have these membranes that rupture before contractions, and the gestational age here is 20 weeks and before the completion of, and before 37 weeks gestation. So who's at risk for developing PPROM here? If we have a prior preterm birth, people with a short cervix, any second or third trimester bleeding can increase their risk factors of developing premature rupture of membranes here. So what's going to happen? Your patient's going to either call their physician or show up at the hospital thinking that their water has broken, regardless of gestational age. You cannot diagnose this without coming to the hospital or going to the doctor's office. You can't do it at home. So they're going to come in. Let's just say they're going to come into the hospital with a complaint of leaking fluid. They think their water broke. So we're going to walk them to a room, have them change their clothes, put them on the monitor, establish fetal well-being, do an assessment on the patient as well. Now what we need to do is we need to establish if they're ruptured or not. So we ask them to describe what they've experienced. Have they had to wear a peri-pad in? Is the peri-pad saturated? Those kinds of things. And then we're going to do some diagnostic screenings to see if this patient is ruptured. There's 2 things I'm going to teach you about: ferning and nitrazine. And ferning, like it says there, is the most accurate way to diagnose rupture of membranes. So we are going to do a history on our patient, call our healthcare provider. Our recommendation is to get these diagnostics done, a ferning and a nitrazine, okay? And then we're going to go into our patient and we're going to see if we can get some of your fluid. Before you go see your patient, you're going to go into the supply room and you're going to get an upside down, you're going to get a fracture pan, you're going to get a speculum with a light, you're going to get sterile gloves, you're going to get a microscope slide, a Q-tip, and some nitrazine paper or pH paper. And take all your stuff into the patient's room and tell them you talked to their healthcare provider. They want us to see if we can get some fluid. And you'll be like, all right. So you're going to put them on an upside down bedpan. Again, we are putting them in this position. It puts them in a pelvic tilt so I can see the cervix. You need to see the cervix, all right? And it's easier for you as the nurse. It's also easier for your patient as well. It hurts them less. Open up all your supplies. Get your gloves on. Put your speculum in, put your light on, and then you're going to look at the cervix. Again, it looks like a little donut hole. We already talked about that. And they're going to be probably in a low phallus position so you could see it. And what you're looking for before you do anything else is you're looking for the accumulation of fluid in the posterior fornix, which is, remember, that's the little pocket behind the cervix. That's called pooling. That's pretty indicative. Also, the next thing I want you to do is I want you to tell your patient to cough. And when they cough, you might see amniotic fluid coming out of the cervix. Okay? So the next thing you're going to do is you're going to take a Q-tip and you're going to put it in that pooling or wherever the pooling where you think it might be and see if you can get some fluid on the Q-tip. Take your Q-tip out. Take the speculum out. I want you to drag the Q-tip onto your microscope slide. And I want you to also drag the Q-tip onto this pH paper. take off your gloves, get all your equipment, put your patient settler, and then I want you to go into where the microscope is, and I want you to put the slide under the microscope. And if she's ruptured, it'll look like this. It looks like a fern. That's why it's called ferning. There's only two things that look like a fern. The plant, which you shouldn't be seeing at this point, and also amniotic fluid. There are other things. So let's talk about this pH paper here. So why is this not the most accurate? pH paper, before it comes in contact with any fluid, is this yellowy gray color. When it comes in contact with amniotic fluid, I'm going to get my eraser because I drew over the color. When it comes in contact with amniotic fluid, it turns that blue color right there, okay? Or it's more of like a purple. That's great, but there are other things that can cause it to turn this color. Blood, semen, and urine. So it's not the most accurate. Where ferning, that's the only thing except for the plant, okay? So you're going to call your healthcare provider back, and you're going to give them results of your test. And if the ferning is positive, they're going to be admitted until they deliver, regardless of gestational age. Even if they're 19 weeks pregnant, 20 weeks pregnant, they're going to be admitted until they go into labor or until they get to be term, and they'll do a C-section on them. More often than not, depends on the doc. But if they're not ruptured, they'll get sent home. Remember, if somebody's ruptured, regardless of gestational age, we're doing more careful assessments of temperature and monitoring the uterus to make sure it doesn't become infected, because it's just a muscle. And if you palpate a sore muscle that's infected, it's going to be sore, right? So lots of palpating of that muscle, lots of temperature checks, and it's not uncommon for your patient to get antibiotics prophylactically. And this concludes our Antepartum high risk content.